think it's time to start back to the program. So welcome back to our next keynote lecture. We are honored to have Professor Mohammed, who is the consultant hepatologist from Department of Internal Medicine at University of Malaya, Malaysia. She's also a Deputy Master of Academy of Medicine of Malaysia. She's also been appointed as a co-chairperson for the WHO Global Strategic and Technical Advisory Committee for Viral Hepatitis. She will give us a talk on acute hepatitis B infection.
Okay, thank you. Okay, so all of us are very familiar what constitute chronic and resolved hepatitis B infection. But that's now increasingly recognized that those who have so-called recovered from hepatitis B infection may have low-grade viremia but absent serological markers of hepatitis B. And unfortunately, this group of people are clinically relevant because they are equally susceptible to the complications of chronic hepatitis B infection. And these are the acute B infection. So EASL in 2008 defined OBI as presence of hepatitis B DNA in the liver tissue with absent HBsAg with or without serum DNA level. And if the serum DNA level is detectable, they're usually very low, less than 200 IU per mil. Now, the more widely used definition of OBI is persistence of hepatitis B DNA either in the hepatocytes, serum, or peripheral mononuclear blood cells, but in the absence of HBsAg. Now, the studies have now shown that OBI is more often detected in patients who are negative for anti-HBs. Presumably, these patients lack the neutralizing effect of anti-HBs. So if you look at the pattern or serological pattern of acute hepatitis B infection, this can be divided into seropositive or seronegative OBI. And this is actually defined, seropositivity is defined by presence of anti-core antibody with or without anti-HBs. And this constitutes about 80% of OBI, whereas 20% is seronegative for all markers of hepatitis B. And what is interesting is that the study by Zabini et al. Showed that those with or without anti-core antibody have different profiles of the T-cell responses. And what is shown here that although the T-cells, the actual frequency of detection is similar in the two groups of patients, what is shown is that those with OBI seronegativity have in vitro expansion and weaker interferon gamma production by the HBV-specific T-cells and compared to the seropositive individuals. So there are some distinct differences between seropositive and seronegative OBI. And the woodchuck animal model showed that the possible mechanism or possible reason for these differences may be related to the different modes of transmission of the two. And I'll try to explain in this slide here. So seropositive OBI can be either due to the fact that these people have recovered completely from acute hepatitis. So they don't have the HBsAg, but they actually have the core as well as the with or without anti-HBs. So another group is they have been long-term persistent HBsAg positive, and then after many years, they actually lose their surface antigen. And this can happen in a substantial proportion of individuals. Whereas the seronegative can either be due to these antibodies being present at the beginning, but they progressively disappear over time. And the last group here in the negative individuals, these people had acute infection but never developed antibodies at all from the beginning. So these are primary occult infection, and the actual hypothesis that these people were never positive for the serological markers is that the amount of virus in the infected inoculum is very low. So this is similar to what is observed in the Woodchuck model of Hepatna virus infection. So OBI is recognized, it can be part of the natural history of perinatal acquired infection. So this group of individuals, they go through the usual phases. After the immune clearance, they go into the low replicative phase, and after many years being in the so-called inactive carrier state, may spontaneously lose the surface antigen, and this more commonly occurs, of course, in endemic areas. And what is shown is that these people with OBI may be either the seropositive or seronegative using the mechanisms that I alluded to earlier. So they will probably, after many years in the seronegative cases, lost their markers for anti-HBC and anti-HBs. So the prevalence of OBI remains unclear, and there are several reasons why it is very difficult to determine the prevalence. And most of these studies are small and they lack appropriate controls, but also a challenge is that these people have low levels of DNA in the serum. So sometimes it gets detected and sometimes not. But one of the main reasons why, to date, that it is thought to be generally underestimated is because we do not have a standard assay to measure the DNA in the liver specimen. So what is found from studies is that OBI prevalence seems to be higher amongst those at high risk of hepatitis B infection compared to those who are low risk. And of course, the other group of people that we actually expect the higher prevalence of OBI are those with chronic liver disease rather than those without chronic liver disease. So amongst the chronic liver disease, the higher prevalent group are those with hepatitis C or HIV population, and also people with liver cancer regardless of the cause. Now, amongst those with cryptogenic liver disease, there are about up to 1/3 of patients may have OBI. And I will actually show you some examples later on. So the prevalence that has been reported amongst those who are core antibody positive of OBI is between 4 to 25%. And amongst those, if you just measure whether or not they have detectable surface antigen, the prevalence can range from as low as 0.7% to 16%. So I'll be showing you 3 studies to have an idea on the prevalence. And one of the largest study is actually from Australia, and they looked at nearly 1,500 serum samples, and they tested for the following markers: DNA positivity, hepatitis B surface antigen, and the core antibody. And what was found that only 10, which is 0.69%, fit the selection criteria for OBI. Now, in this Korean study, the prevalence is high, and this is quite surprising because they're looking at healthy subjects with normal serum ALT, and when they measured the DNA level, 31 out of 195 were found to be DNA positive, but no surface antigen positivity. And this Korean study showed a prevalence of 16%. So in another study from China, this is looking at subjects with detectable DNA but no detectable S antigen. Again, these are healthy subjects, and the prevalence here of OBI is 6%. So there's a wide range of the prevalence of OBI depending on the population that's studied. So in persons with S escape mutants, so I think some of you are familiar what S escape mutants for. there are presence of the episomal free hepatitis B genome at the intrahepatic level. So HBsAg is present, but it's not detectable. And the reason for it, because of this mutation occurring in the pre-S region, which is not recognizable by the commercial available kits. And sometimes this is referred as false. These are referred as false OBI because the surface antigen is actually there, but it's just not detectable. And this has been reported in up to 40% of patients with OBI, but in general, it's very low occurrence. So amongst those with OBI, a small percentage is actually really, if you look at the definition, will be due to the S escape mutants. So the way to actually go about trying to actually not have a false OBI is the use of these multivalent anti-HBs antibodies for detection of the OBI. So currently, the molecular basis of OBI remains unclear, but is thought to be related to the peculiar life cycle of the hepatitis B virus, particularly due to the fact that the covalently closed circular DNA is actually persistent in the nuclei of the infected hepatocyte. So that's thought to be the molecular basis of OBI. And this cccDNA is formed usually within the first 24 hours following viral inoculation, and it gets converted into a mini chromosome within the nuclei. And the way you can detect it is only by using a tissue assay from a liver biopsy. Now, cccDNA is extremely stable, and the stability, together with the long half-life of the hepatocytes, means that hepatitis B infection, once it has happened, may possibly continue for life. And what is interesting and what should be actually really stressed is that the cccDNA will persist indefinitely independent of the S antigen status. So this is a schematic comparison of overt and occult infection. I mean, it's very busy here, but I'm just going to show you that most cases of OBI, the actual, the reason for the inducing OBI is related to the host, and it's because of the replication competent viruses that are strongly suppressed in the activities by the host defense mechanism. And the proof that the host play a predominant role in inducing OBI comes from this study, which showed that once you actually take these isolates out, the replication, the transcription, and the protein synthesis abilities of the isolates can be fully restored once the virus are taken out from the host liver microenvironment. So let's look at overt hepatitis B infection. And we know that in overt hepatitis B infection, one of the main things that happen is they have a dysfunctional T cell. And this antiviral T cell dysfunction is maintained by several mechanisms, but one of them is because of the fact that there's persistent exposure to the high antigen level in the patients. And that actually precludes the generation of functional efficient memory T cells. In contrast, in occult hepatitis B infection, there is actually potent T cell response, and this actually will lead to the virus being tightly controlled by these T cells and can actually lead to rapid expansion or differentiation of these T cells once needed. So what is going to happen is that these actually are all related mainly to the T cell response, but there are also studies to show that the innate immune response might also be involved in the suppression of hepatitis B replication through the non-cytolytic immune-mediated mechanisms. So let's look at the mechanisms leading to occult hepatitis B infection. And these are very busy trying to show you that there are many possible mechanisms, But one of the main mechanisms, as alluded to earlier, is related to the immune system. And one is because of the functional efficient memory T cells. The converse may also be true when you see that these actually OBI occurs when there is co-infection with HIV or HCV. And the other ways that has been implicated are the formation of the hepatitis B immune complexes. Now, there are several genetic mechanisms that have been implicated, which include the variability in the genome sequences, also the sequence variations shown here, and one of the other thing which plays a predominant role in some cases is actually the role of the apolipoprotein B editing enzyme catalytic polypeptide. And I won't go through details of this. To us clinicians, it is a little bit hard to grasp this concept. But the epigenetic changes have also been shown to play a role. And this includes the methylation of the CpG rich regions within the hepatitis B genome and the acetylation of the cccDNA-bound histones. Now, just to show you very briefly, although I have mentioned that the genome mutation plays only a small role in the cases of OBI, let's look at some of the hypotheses or postulations on what is the mechanism in these circumstances. So globally, this G14R mutation in the surface genome has been associated with immune invasion. So there are some studies to show that mutations in the A epitope within the surface gene can cause reduced binding of anti-HBs, as shown there, and leading to immune invasion and therefore continued replication of the virus, albeit at the low level. Now, the mutations due to antiviral agent with low genetic barrier to resistance may also play a role and may actually have some mutations here giving rise to small levels of viral replication in the virus, and that is associated with the OBI. And a very small percentage also is due to the viral defective particles, and these viral defective particles may be due to the mutants with defective replication or the synthesis of the S proteins. Now, I think what is important for us to note is the clinical significance of OBI. So what I'll be showing you is these scenarios in which OBI may occur, and what I will actually cover is mainly the role of the OBI in hepatitis B reactivation of the virus, the role of OBI in the transmission of a occult virus mainly through blood transfusion or organ transplant, particularly a liver transplant. And I'll also show you the effect of progression of OBI in chronic liver disease, and we'll focus on mainly on hepatitis C. And lastly, the role of OBI in the development of liver cancer. So first, let's look at the hepatitis B reactivation in patients undergoing immuno or chemotherapy. And this actually is important because it provides an indirect proof that the immune or the host immune response plays a role in OBI. So before that, let's briefly look at the definition of hepatitis B reactivation. And to simplify things, it's just reactivation means that when there is increase in hepatitis B replication. So there are, in a person with surface antigen positive, two different ways we can look at, or two definition of hepatitis B reactivation in this setting. It can be either a rise in the serum DNA level from baseline, and that rise is usually in the region of more than 2 logs. And the other circumstance is the appearance of DNA from being DNA negative to being DNA positive. So that's in the surface antigen positive patients. In the patients who so-called recovered from hepatitis B, there are two circumstances where hepatitis B reactivation can occur. So one is actually when you have reverse seroconversion. That means they were previously surface antigen positive, but under the effect of immunosuppression has become again surface antigen positive. And the second group is the appearance of DNA in a person without the appearance of surface antigen. So this person was DNA negative and becomes DNA positive without HBsAg. So this is the group that we're going to be focusing on because this is where OBI may come in. So if you actually looked at those who are surface antigen positive, there have been many reports now, it's well recognized that you can get hepatitis B reactivation in these various immunosuppressive settings. So the incidence in this various setting can range to as high as 90%. And that is expected if a person is surface antigen positive. But what about if a person is surface antigen negative but core antibody positive? And you can see that as expected, the incidence is lower compared to those who are surface antigen positive. But we can see here, there are certain scenarios where even the incidence can be as high or nearly equal to those who are surface antigen positive. And these are in the setting of bone marrow or stem cell transplantation, and those who receive very strong immunosuppressive agents such as monoclonal antibodies to the B or T cell, specifically the anti-CD20 and anti-TNF. So let's briefly look at the pathophysiology of hepatitis B reactivation during chemotherapy. And typically, these can be divided into three phases. Now, the phase one is whereby there's increase in viral replication with a rise in the DNA level due to the immune suppression. Now, during the second phase, there's hepatic injury because of the immune rebound as the host immunity has recovered upon withdrawal of the chemotherapy. And in some circumstances, these can actually lead to very high levels or ALT flare, and this can lead to liver failure and even death. Now, the third phase is the recovery phase, and fortunately, most cases recover spontaneously, but there are some patients who may have worsening of chronic hepatitis leading to cirrhosis. So the hepatitis B reactivation, although I have shown you the reports early on the incidence, but actually it is unknown how common the hepatitis B reactivation occurs in people with so-called resolved hepatitis B infection who may have OBI. So I'm just showing you this example, one of the largest studies, although it's a retrospective analysis. This study included nearly 700 patients who are S antigen negative but anti-core positive. And they looked at two scenarios. One is in those undergoing treatment or chemotherapy for solid cancers, and the other group are people who receive chemotherapy for hematological malignancy. So you can see here that hepatitis B reactivation occurs at 0.3% in those with solid cancer compared to 3.3% in those with hematological malignancy. So 10-fold higher risk in those with receiving chemotherapy for hematological malignancy. And this study showed that the risk factor for having hepatitis B reactivation in this group of patients one is the disease factor, where the underlying disease treated is lymphoma. And the other important to note is the viral factor, that is absence of anti-HBs in these people with past infection. Again, eluding the fact that the lack of anti-HBs may be related to the lack of neutralizing effect of the anti-HBs. Ooh, what happened here? Okay, never mind. So these are actually looking at this group of people who receive anti and TNF agents, and this consists of about 17% overall of cases that have been identified. And if you look at the breakdown into those who are S antigen positive, 39% occur in those who are S antigen positive, and 5% occur in the surface antigen negative but core antibody positive. So the OBI is thought to be in the region of about 5% in these individuals, giving rise to reactivation. So let's look at how we can prevent hepatitis B reactivation in this group of patients. So we know it's well recognized that prophylactic antiviral therapy in those who are surface antigen individuals, positive individuals, can reduce hepatitis B reactivation, and this is one of the systematic review of 14 studies which showed that the antiviral therapy reduces the risk of hepatitis B reactivation, hepatitis B-related hepatitis, liver failure, and death. So nearly 100% of liver failure can be prevented with the use of antiviral therapy. Now, there are very few studies, these are randomized in this area, and even fewer in those who are core antibody positive. And then one example of such study is shown here, and it showed that the use of lamivudine, although it's very small numbers here, the use of lamivudine is associated with reduced rate of reactivation, only 2% compared to the control group with a hepatitis B reactivation rate of 18%. So what it showed that the prophylactic antiviral therapy is equally effective in this small study in the core antibody positive individuals. Now let's look at the guidelines or what the experts say about what we should recommend as screening as well as antiviral prophylaxis. So these are various guidelines that have actually looked at the screening and the use of routine antiviral prophylaxis, and they mainly refer to the surface antigen positive, but there are some things being mentioned here with regards to the core antibody positive. And in general, this group is not recommended to actually have routine antiviral prophylaxis, but they should be monitored during treatment and watch for reactivation. But I'll show you other newer recommendations, and one of them is actually from Professor Reddy's team from the AGA guidelines on the prevention and treatment of hepatitis B reactivation during immunosuppressive therapy. And the key recommendation from this guideline with regards to this topic is that you should screen patients with surface antigen and anti-core in all those undergoing chemotherapy or immunosuppressive therapy, and the antiviral agents are recommended in those who are at high risk. So we see this clearer in this algorithm. So here, all patients before immunosuppressive therapy are recommended to have surface antigen testing as well as core antibody testing. So if any of these are positive, then further assessment is needed with hepatitis B DNA, and those who are at high risk should receive prophylactic therapy. So very quickly here, this table shows the risk-based prevention strategy for hepatitis B reactivation, and in general, those at high risk, when it refers to the core antibody positive, only actually the one that's supposed to receive antiviral therapy are those who receive B-cell depleting agents or chemotherapy for hematological malignancy. Okay, so the last few parts of the slides are actually on the other categories of clinical significance of OBI. And one of them is on the blood transfusion. And it does pose a risk because you can transmit OBI even with very low levels of DNA. Even if it's less than 20, there's still potential risk of transfusion-associated OBI. So there are three circumstances whereby transfusion transmission of hepatitis B may occur. One is when the donor is in the window period, or what they call as eclipse phase, where neither surface antigen nor DNA is detectable. Secondly, when the donor is a typical OBI carrier with a wild-type virus, where there are periods of transient hepatitis B viremia alternating with periods where the DNA is, again, very low and is undetectable. And the third scenario is when you have infection with the variant hepatitis B strains I've mentioned earlier, the S escape mutants, which are not recognized by the conventional commercial S antigen detection kits. So amongst the three scenarios, the common one, the first is not common, only this nowadays is actually a way of transmitting. This is a major cause of hepatitis B transmission by blood transfusion. So fortunately, because nowadays we actually have very sensitive and specific diagnostic methods to actually detect the serological markers of hepatitis B, the risk of blood transfusion has dramatically reduced, and that's because most centers now use nucleic acid testing to identify blood donors with circulating hepatitis B DNA. What about in the context of organ transplantation? And I will only mention about liver transplant because in liver transplant, when you looked at the de novo hepatitis occurring in those who are HBV negative recipient, then you can only see this happening in the context of liver transplant compared to other organ transplantation, and mainly because the hepatocyte is the major reservoir of the HBV CCC DNA. Okay, so my time is nearly up. So what I will actually mention very quickly is in the setting of chronic liver disease. OBI is highly prevalent, and particularly amongst those with hepatitis C. And when it was first discovered, most of the OBI that was seen was associated with the most severe form of hepatitis C-related liver disease and has been implicated in the progression or the rapid progression of hepatitis C. So in terms of prevalence amongst hepatitis C, up to 30% of people with hepatitis C may have OBI, and if you look at the liver biopsy, the prevalence is even higher, up to 50%. And very surprising is this study from those Caucasian patients undergoing liver transplant for hepatitis C cirrhosis, and you expect that the hepatitis B is going to be very low in this group of patients, but 50% of these individuals were OBI positive. Okay, I'm just going to skip that. And the last part is looking at OBI and liver cancer. So just one thing to actually note, that now there's overwhelming evidence that OBI is associated with increased risk of liver cancer, and this meta-analysis showed that this is true. And the reason for the occurrence of increased risk of liver cancer is related to both direct and indirect mechanisms. So to conclude, we actually should be aware of this entity of OBI, and it's related to the long-term persistence of hepatitis B CCC DNA in the nuclei of hepatocytes. And to date, what seems to be shown is that the host factor plays an essential role in inducing OBI, and the clinical impacts of OBI in the various settings should be looked at, especially in the reactivation of so-called resolved hepatitis B cases. With that, thank you.
Thank you very much, Dr. Mohammed. Due to the constraint of the time, I will end my session at this moment.